You know, we usually say these things to others as a way to say, this isn't that difficult. That when we try and explain to upper management or to our bosses why something happened the way it did, we start explaining all the difficult that's in the process. How an error wasn't quite as simple as we thought, how it's not just writing down a name and number on a piece of paper anymore, and we start to get more and more elaborate with our answers of why our processes were so difficult. But when we talk to our staff, we sometimes say, you know, this isn't brain surgery, it's not rocket science. And although claims billing doesn't have the same level of risk as those jobs might, there is still risk within the system. It is very complex, we all know that, and we often forget the mechanics involved and how difficult it really is. Managing denials is, of course, costly in terms of time and money, and establishing an effective denials prevention process is crucial into the long-term success of your practice. So my takeaway here is that although we don't have inherent risk of killing someone on an operating table or having something blow up on launch, what we're doing today, and our focus today, is how to lessen our denial process and mitigate our risk in preventing future denials. Yearly education. Everybody, I'm sure, gets questions about attending conferences and I need this education or I need these books, and the cost can be staggering sometimes, especially to smaller practices or smaller facilities. And what you learn from costly user group conferences is more networking sometimes than actual functional knowledge that you can put into the workspace. And leadership may not want to invest in what they might perceive as expensive training that might break the bank. So I want to talk about some of the numerous ways that we can do this inexpensively or even free. There are a lot of certification program training out there and CEUs that are minimal, $45 or less, $15 on some of those. There's business partner training webinars like we're doing today that can provide education and ongoing benefit. And then, of course, there's all your commercial payers and federal payer website training programs if you're not aware of those. I know a lot of people are because I know a lot of people use them. Probably the most elaborate one that I've seen is offered by CMS by Medicare, and they offer this comprehensive web-based training program through their MLN learning management systems. And I've put a few of the courses that are up there that they offer up there. This is not a comprehensive list. It's pretty exhaustive, in fact, when you actually get out there. And they keep it up to date. Every 12 to 18 months they add new programs, or they add new literature, or they add new research. And this is directly from the Medicare website that I posted here today. And although it's just Medicare, it does help with basic understanding of coding and payment policies. And what's really nice about the MedLearn program is that they provide CEUs. They'll archive your training. They'll prompt you for new training. And they produce certificates for CEU proof. And you can have your trainer, if you're lucky enough to have a trainer, go out there and assign these to individuals, and then they can perform them, print the certificate, give that to the trainer, and show that they've done this. Most of the tests do allow for multiple retakes, and this is all free. I like this program a lot for my Medicare and Medicaid billing staff because we can get down to the basics. These are usually the ones that I employ, that they learn. These are not easy tests. They are all web-based available, so you're not having to do any pen and paper, and they come with wonderful literature and research behind each one of them. I would recommend this to anybody, especially if you have new staff that haven't done this before. One of the biggest issues that we face is that the most effective method is to use denial data that's already out there. I think that a lot of times we do this train the trainer thing where the person before you trains you on how to do it, and they start with a process that's already in place, that's key, that everybody knows about, but you don't get a feeling of accomplishment if you're not working current denials, if you're not actually resolving issues as you work. And to put in place a quality assurance audit process for registration, you have to be tracking these things on the back end, and you have to have a consistent audit process, which we'll talk about later in this program. There are multiple vendors out there that have QA systems that employ a scoring methodology, but a regularly scheduled audit of selective quantity of encounters is a worthy place to start. A lot of people like doing this and working current denials versus past denials or past problems. Those all have their place, and everyone should be aware of them so that they don't recreate them. But again, I would say the most effective way is to actually have them work denials as they go through the registration training process. Pre-service denial prevention is our next area we're going to talk about, and what I mean by this is what you do prior to the patient arriving at your facility or your practice. Every good revenue cycle manager knows that the best defense is a strong offense. Pushing error identification or denial prevention to the front end lessens the turnaround time on getting paid. But that's often easier said than done. Up front is where the patient's located. It's the easiest way to get that information. A lot of people don't like calling and asking for that information over the phone. It just seems tedious and time-consuming, but that's where it needs to start. There's also added pressure from upper management to get the patient through fast. You know, if you're on the phone for 10 minutes trying to get all this information, then you're not answering calls or you're not dealing with patients that might be in front of you. So I know that happens. KPIs for registration departments usually include time metrics for processing patients. So if you've got somebody on the phone all day and they're not processing patients that are there in the office fast enough, that pressure can be overwhelming at times. Faster is not always better, though. Patient complaints often refer to how long they had to wait and how many questions they had to answer. If they're doing that on the phone the day prior or 2 days prior, which is recommended, then they're not doing it at the office, and that things do go faster. So the simplest answer is to begin the process prior to the patient's arrival if possible. But I hear from every office that I go to that sometimes it's just easier when the patient arrives. They'll figure it out when the patient gets there. It's too hard to explain to them over the phone. They don't understand. Or worse, let it handle when it gets to billing. We'll figure it out when we get ready to bill the claim. Again, we hit things that will stop the patient from being seen by the provider. We always get those things. You've got to have a referral. You've got to do this. You've got to do that. That we don't often hit the things that will stop the bill from going out, and we worry about it later. It's always best if you can start to predict the denial through post-denial data collection reviews. That's a pretty vague statement, but what I mean is if you're seeing a certain denial from a certain payer and you can start to figure out what the payer is doing by trending and looking at that and looking at where they're looking, then that helps the most. You always want to move those processes to the front end. You want to make sure insurance verification is not happening at the time of billing, that financial assistance reviews have been done prior to the patient actually getting the bill, that payment balance estimations are given at the time of that 2-day ahead phone call, and patient balance collections or payment plans are reviewed and enacted before the patient even arrives. Those are best practices. Pre-service denial prevention goes even further. You need to verify procedure information or the reason for the visit. I've seen a number of times where wellness visits have been scheduled or have been thought to have been scheduled, but it's really just an E&M visit that's been scheduled. And then we're having to deal with it at the practice level when the patient gets there and we're collecting copay and the patient's telling us there is no copay because this is a wellness visit. So get those procedures scheduled correctly. Capture referral information as applicable. Always ask if there's a referral that's needed, and get that referral prior to the patient getting there. Nobody wants to wait to be seen, waiting on a fax or a phone call for a referral. Obtain and verify necessary demographics. You know, we think that if we just capture the date of birth and we just capture this or we just capture that, if we know that the system requires it and the bill requires it, we need to capture it at the time of service or prior. Check eligibility verification. A lot of times what I see is I see offices that send it out once, and if it comes back and it's not valid or the system's down or the payer's not available, they don't go back and re-verify. If you're doing this type of verification prior to the patient coming in, or you're doing it at the time of service, or at the very least before the patient leaves the office, then you'll have a much higher rate of a clean claim. Capture all insurance is applicable. I see a lot of offices and a lot of facilities that capture the primary but rarely ask for the secondary. Even in this day and age, it often surprises me that we don't ask for secondary information. Obtain pre-auth when required. There's nothing worse than 5 days after the patient's left and it's going through the billing process to realize that you need an authorization. And we'll talk about how to make sure that those are getting captured later on. Be aware of denial traps. Medicaid MCO plans require things like the patient, selects their provider. Those are easy to ask that question and to steer the patient in the right direction. The same for wellness. If you know that wellness is a problem because you're not booking it that way, then identify those things. The model pre-service denial prevention process must consist of all of those things, and it should happen prior to the day of service. We're not talking about emergent or urgent or add-on patients at this time. But collecting patient payment using estimation technology to calculate and collect any copayment, deductible, coinsurance, any type of patient responsibility is also key. No one wants to be shocked when they get to the office or they get their EOB in the mail saying that they owe something and no one's told them about that. We always talk about taking care of the patient's health, but we rarely talk about taking care of the financial health of the patient. And those are services that we can provide that do a good job and that help that health of that patient. By taking these steps, I think patients can be cleared financially prior to the procedure, or at least be aware of their amounts and have payment plans in place. The next topic that we're going to talk about is cleaning up your registration system. A clean registration is vital. It really is vital to a clean claim. I know that everyone on this call has probably heard this, but don't read information to the patient. I was in an office yesterday, and they absolutely did this. They said, so are you still at La Lane? Are you still, is this still your phone number? Do you still have this insurance? And then read it to them. And the patient had 2 children with them, pediatric practice. They were just trying, and they were just going, yeah. Request information from the patient. Don't read it to them. Verify all information, even if the patient was recently at the hospital or practice. Information should be reviewed at every encounter. And yes, the patient will complain that they have already told you and all of this information, and you keep asking the same information. Have a script ready that basically says, we do this for your benefit. Explain to them briefly why it's important to re-verify that information at each visit. Now, I know that there are infusion clinics out there. I know that there are physical therapies where you're coming back in, and that information's good for a reasonable time period. So common sense comes into play. You don't have to recertify. You don't have to re-verify. You don't have to get a pre-auth and that type of thing for those situations. But for your routines, yeah, you never know when something changes. People get divorced. They lose jobs. They don't pay their premiums. Those things happen, and they can lose their information. People move every day. I have never not witnessed this. Everyone does it, and especially for patients they know. So my suggestion here is always request that information. Clean up your patient registration system. Do regular maintenance. Have a process for duplicate records. There's nothing more fun than having 14 of the same Mary Jones in your system and not knowing where the charge lives. Assign required fields as necessary. Don't be afraid of this. It was created for a reason. If you need to make a field required, make it required. People are going to complain, but there's a reason for it. Check format fields for errors. If there are special characters that cause problems, publish these where everyone can read them. Simply say, don't use a hashtag, it will cause errors. You know, people need those constant reminders. They forget these things with the multitude of tasks that they have on hand. Other things in your system are your dictionaries, payer code dictionaries, payer code crosswalks, payer plan codes, NCD, LCD updates. You need to have a process in place to review these on some type of routine basis. Building them is hard, and maintaining them is just painful, but it has to happen. A plan for regular monitoring of such issues will help avoid billing errors and costly denials down the road. Our next area is pre-bill review, or preview, I'm sorry. In this area, we're going to talk about determining the issues regarding insurance coverage and benefit eligibility, producing daily feedback sorted by employee if possible regarding denials, retraining to resolve identified problems, and target training. So what you've done now is you've educated and trained for your job. You've provided tons of information to these employees and to management and to staff. You've made it through the pre-service denial prevention clearance. You've done all of this stuff before the patient ever gets there. And you've got your registration system in great shape. Now it's time to deal with those issues that might seem to be outside your control. You rarely create them, you just have to abide by them. And these are usually your payer rules and edits with your clearinghouse and your scrubbers. Since we have evolved as an industry and we're not doing things with chisel and rock, although we still may be doing them with paper and pencil, most revenue cycles, whether hospital or practice, employ some type of scrubber or editing system. The necessity at this point is to identify the denials hitting those edits by location and prepare to push them back to the front end. If I can reiterate anything today, is push these things to the front end. Make sure the denial never occurs because the error never occurs. You need to always be able to track and trend your denials. You have to examine registration-related denials, and as you get more into a prevention program, you'll realize that most of the errors are registration errors that can be prevented if we're capturing correct information up front. You may wish to appoint certain employees, it might be you, even to take charge of correcting the problems or simply reviewing them. If you use the latter route of just reviewing, be wary that informational reports tend to get set aside and ignored when you're busy. Follow-up has to happen. The back end probably has fixed the problem by the time the report is even reviewed, so you don't see the urgency or the need on a consistent basis to do the training back to the front end because the problem's been fixed. You'll get to it when you get to it type thing. You have to target training. Training is best targeted to the needs of the individual employee who requires intervention, we all know that, as well as periodic refresher updates for the entire team. Some of these pre-bill previews that we see are coding issues, of course, because outside CPT codes and diagnosis codes and ICD-9 and 10 codes that we're still dealing with, and then you throw in modifiers and all that's quintupled since 2014, you're faced with just this huge web of literally millions of code combinations. And it's no wonder that we have denials because of this. The key to solving coding-related denials is, of course, seizing the opportunity at the initial determination of the code, not after the fact. If we push education to the front on code issues that we have, through trending of these errors, educating of the staff, educating of the providers, and the use of technology, we can see a decrease in these code-related errors happening. We need to identify common services, gain expert advice on how to correct them. You have to network with colleagues in your specialty, as they may have coding tips to share that you don't discover on your own. You can prevent coding-related denials by providing physicians with excellent training, because we all know physicians love to be trained on coding denials, but it's appropriate, and we can tailor that down to what is causing the most denials. Don't stop with training, however. We need to use information technology to automate verification. You have to have NCII edits in your system. You have to have LCD and NCD edits in your system. And you have to create your own edits when you know that things are happening, whether they're bundling errors or mismatched errors or modifier errors. You have to have those in place. My greatest success with dealing with providers is by not really preaching fear of the impact, but to educate on the consequences. Give them the impact. Tell them, you know, this is what we're seeing. We're seeing when you do these two codes together, it's causing this much financial impact. You know, hospital-based employed physicians or large practice employed physicians don't always understand that until you break it down to them specifically and their impact. And you can do that by trending and tracking those denials. Another issue is to ensure the information is captured consistently throughout the organization. Whether you're small or large, revenue cycle leaders need to educate physicians about the advantage of collecting the proper data for each patient. You know, if it's not impacting them by saying, you know, this is costing this much money, bring it down to reality. This is costing the patient this much money. The patient will be balance billed because this wasn't medically necessary. Those types of things. I just spoke to a provider today that she assured me his office had completed all the required information needed because they told him they had. All it took was a screen print of his fee ticket to correct that situation. There was no address on the fee ticket. There was no insurance on the fee ticket. There was some codes and a signature, but that was all. So these are things that I know everybody deals with daily. One of the biggest areas that we deal with pre-bill preview is authorization denials. Whether your facility or your practice, authorization denials are becoming paramount to getting paid. You have to identify services, of course, that need authorizations. The fastest way to do that is check with your payers. They all process handbooks for their patients. They all print this out on their websites. They're telling you what's going to require an authorization. You need to build those into your system in an automated process. You need to set up alerts for add-on cases and visits. There's nothing like getting an add-on case and an authorization was required. It's not urgent or emergent, and then you get the bill, you're working the bill a few days later, and you realize that you've already missed the timely filing of the 2-day authorization review. You need to track these denials by location and person and collect the denials from the back end to improve the front end. I think that this one is probably the most frustrating because we know that they're required, we know that they have to be done, and when they're not done, we tend to get aggravated with each other. We have to institute a system to automatically query appointments for the prior authorization status for all scheduled service. And you have to, again, let me reiterate, alert employees to investigate prior auth requirements for all in-office services that are ordered on the spot. Then you have to work the retro denials. If you need a retro authorization, normally payers are giving, if they allow it, are giving 48 hours. You have to go back through and see anything that didn't have an authorization and stay on top of that. If you miss that 48 hours, appeal anyway, because sometimes the payer will see your side and pay. I'm not saying do that for a $20 case. You know, again, common sense would say if it's a larger dollar amount, I would go ahead and try to appeal. Medical necessity edits are one that I know we're all familiar with as well. Of course, we need to deploy software that edits charges for coverage determinations. These need to come from your insurer, whether it's an NCD, LCD, or benefit-specific policy. They should be integrated into your system, along with the source for the edit would be helpful. To develop internal knowledge among providers and billers, gather all of your insurance policies regarding medical necessity and conduct training. Even if it's memos or notes or post-its somewhere around the system, something, I promise you, is better than nothing. You need to query insurer websites and ask provider reps too, because payment policies can change at any time. I know a lot of people are doing fax blast and web blast, and they're not always reaching out to the entity to tell them about an update or to tell them about a problem. They're just assuming that you'll go and read their stuff every day. We know this doesn't happen. Then you need to organize the policies by subspecialty or service. A frustration for physicians and providers alike is receiving denials when the insurer claims the diagnosis provided does not support the need for the service. This is aggravating. But if we know ahead of time what they're looking for and we educate that provider on that, then we don't have those errors as much. If you perform a service deemed experimental, ask the medical director of the insurance with that determination to reconsider. It's worth the effort. Let them know. Sometimes you just need to state your case, and don't be afraid to educate the provider on what you might be doing. Send copies of your appeal letters to patients, encouraging them to get involved too. There's nothing worse than having a patient that doesn't know what's going on, and then they're hit with a balanced bill of a large dollar amount. It's okay to let your patient know what you're dealing with. They're going to know if they call the provider or they call the insurer. Also, along these same lines, be prepared to know when your insurer is going to ask for a peer-to-peer. There's nothing worse than the doctor getting told 10 minutes prior that a peer-to-peer is ready. If they know that it's coming, it's better to be aware than not to be aware. Continuing with medical necessity edits, build edits into your scheduling system. We've talked about that. Be prepared to respond timely. Consult with the provider if necessary. Always save appeals and track and trend occurrences for future use. If your EMR or your EHR is set to provide alerts for services that have been deemed not medically necessary, or those services which have special requirements for medical necessity, i.e. you've had to produce 6 weeks of failed therapy to have this toe hip done, something along those lines. Have those things built into your system so that you're ready and you're prepared to deal with them. Appeal any denial based on necessity by attaching your documentation of the patient visit, as well as any relevant current medical literature in support of that service's efficiency. I'm smiling when I say this because there are usually signs to pre-filled letters. You know, doctors hate writing letters for some reason. I don't know why, but I'm sure we all know why. But if you already have that letter, a pre-filled letter that he has to just review and sign, or maybe add a line to, it goes over quite easily. I had a ED provider once that got slammed with an audit, and when I explained what the provider was doing and what we needed from him and what the financial consequences were to both the facility and the patients, he wrote 85 letters for me, and we won all of them. So I think those are things you have to sit down, and don't be shy about involving both the provider and the referring provider in your process. You have to get out there, and the more support you have, the better the appeal will be. So we've done all this. We've done everything we can to be prepared to prevent denials. So we need to have good processes in place. Prevention implementation, you can call it standard work, you can call it workflow, you can call it a myriad of things, but you have to have a process in place to prevent. If you don't prevent, you're just going to be putting out fires for the rest of the time. We do this because rules change constantly. You have to check your scrubber frequently for edits and updates. You might have, I had a client once that had a 99.9% clean claim rate because they had no edits in place. They were doing it all on the back end, but going out the door, they were reporting a huge sky-high clean claim rate. That should always be suspect. Sorry. In a perfect world, every claim created would be paid on time without any problems. However, people are not perfect, and they make mistakes. And we as leaders are in a position to incorporate processes to help prevent mistakes from occurring and improving denial infrastructures. I know payers change their rules a lot for claim adjudication, and we don't often see that. We just go along with it, and we don't think about how often it changes. But if it's more than yearly, it's too often. In response, we need to have a process in place by which we update those rules and incorporate them into our scrubbers. And we need to make sure the scrubber is vital in our influences of a clean claim rate. I had late loads of updates, or we skipped an update, or a conversation even more recently that we just don't update because we don't have the IT support to do it. Late loads of updates hamper any claims, and you end up doing a lot of rebilling. Not skipping them, you might have missed something in a previous version that didn't get put into the next version. And of course, not doing them, good luck, on those types of things. Sorry, my voice is getting away from me. Implementing prevention, you do want to trend things. I know that this can be a pain sometimes, that we don't always have time to do, but trended denials demand edit resolution. So you want to trend these types of denials so that you can build your own user edits into your scrubber. These usually come along the lines of CPT modifier rules, medical necessity, authorizations, taxonomy codes, credentialing. Staff who update the billing software rules should examine why denials are occurring. And for instance, if certain CPTs are causing denials, they should build a rule into the billing software to prompt staff up front using that CPT to call the insurer for an authorization. That type of situation is what we're talking about here. Internal claim audits. I have been probably preaching this for 20 years, and when it's done correctly, it's a beautiful thing. But people get tired of doing it. That's a human thing, especially when it's going very smoothly and staff have been in place for a long time and everybody knows the rules and we've got good prevention implemented. But internal claim audit has to happen. And this has to be a standard process. It has to be a consistent process. There have to be chart minimums. You have to note corrections as well as noting when somebody does something accurately. If consistently accurate, you need to increase the time span between audits for your employees. If not, decrease the time or increase the amount. This should not be punitive. It should be a coaching opportunity until it's not. If you have an employee that is just consistently not able to do this, this is a good way to review and to track their performance. I would recommend at the end of each week, team leaders or managers or whoever you've assigned pull 5 to 10 claims handled by each member. Grade these claims on how well they're worked, adequate notes, missing information. If the grade is high, like I said, extend these audits to biweekly or monthly or even quarterly. If the score is low, increase that oversight and provide education. You need to position these audits as learning opportunities that advance staff knowledge and make them more productive in their job. I really want to take a moment and tell you that staff really respond initially with dread when they're doing this because they know that they have room for improvement, and it's difficult and it's time consuming and nobody likes to be told when they're wrong. And that's why I say you need to note accuracy just as much. Positive feedback goes a long way. And these should be coaching opportunities. You should be looking to see what they're getting wrong, what they're missing, what they're getting right, what they're doing well. And those things that are trended over time can be pushed to the front end to capture and help that front end staff realize what they need to focus on. I want to include here an example of a workflow document. Some people use Lean Six Sigma standard work processes with screen prints. Those are fine. I know a lot of times people just don't have the time or the ability or the staffing to do that. So just even a simple workflow, post it where employees can see it, is very helpful. This one's on how to capture demographics and validate insurance and present expenses. And it's pretty high level. It was developed for someone that had been doing this a long time and didn't need as much detail. The newer the staff, the more detail that you would want. You can read through that. But have these workflows in place for jobs, you know, whether it's a pictorial or it's a workflow or it's a standard practice. It's good to know all of these things. One of the things that I see a lot when I go out to clients is I see that they have an employee that's leaving for whatever reason, good, bad, or indifferent, and they're doing the training on the next employee. I caution you there because you may be getting rid of an employee or happy that employee is leaving because they've not done a great job, but you're using them to train the next person. And if you don't have standard training in place, if you don't have things like MLN or other types of formal training in place, you probably have some degradation of information as people have trained the trainer, have trained the trainer, have trained the trainer. So you want to make sure that you're reviewing what they're training and that you're making sure that they're not getting bad information that they'll then pass on to someone else in the future. Again, this is just one method that I've used to help people just be aware of what they need to do on a daily basis. And we just walk through some of the processes. And I know I talk fast, and I'm not have any ability to pass any air through my nose today, so I'm again apologize for that. But I wanted to give you a high-level overview on developing an implementation plan for prevention. And I want to say thank you. And I know, Stacy, you have another poll for them, correct?
Yes. One last question. And before we do that, I want to open it up. I don't have any questions through the question panel, but wanted to go ahead and see if people had any questions. So I will give everyone a few minutes to enter any questions that they have. And in the meantime, I will get that poll set up. So the poll should now be available, and I am going to continue monitoring for questions. And thank you very much, Tammy, in the meantime, for a great presentation. And I hope that everyone learned something or quite a bit, and some results are coming in. Don't have any questions yet. Because you were so thorough, Tammy. You covered everything.
Yeah, thank you all for tolerating me today with my voice.
All right, I'm going to leave. Oh, one question. Hold on. Oh, so a question came in on slide deck, and will that be available? So yes, after this presentation, I can get that out to everyone that attended. Okay. Right, so So I am going to go ahead and close the poll. Again, thank you, Tammy, for a great presentation, and thank you, everyone, for your attendance and participation. Hope you all enjoyed the rest of your week.